Back with Dr. Rinaldi. We talked about, ingrown toenail. Let's stay in that area. I don't know whether it is that area, you will tell me, but bunions. And I know that 40 years ago, 50 years ago, the way a bunion was treated, I think it's still treated that way because my father still does it that way. He simply cut a hole in the shoe. And that solved all the problems. So when the first thing after he bought a new shoe, he put a hole in it, and then his bunion stuck out, and he was totally fine. Is that the preferred method of treatment still?
I suppose it's who you're treating. I never argue with success, so if it works, it works. It would not be my first choice, however.
Well, tell us your first choice.
For me, when I look at a bunion, I look at not only the deformity, but I look at the patient in terms of who the patient is, what the patient does, what the patient is looking to accomplish, and how much pain the patient actually has. My first thrust is always to determine whether
if you don't mind,
the deformity itself and the bunion.
Sorry to interrupt you. Can we go one small step back and actually tell us, so that with no uncertain term, what is a bunion in the first place? Why don't we spend a minute or so on that, and then go back on what are the consequences of it and how to treat it?
Yeah, that's exactly where I was going with the discussion. You aren't too far wrong when you said it's not too far from the toenails. In this case, it's not too far from the first toenail. A bunion is a deformity either on the side or top of the foot in what you might, in layman's terms, refer to as the first knuckle or the biggest knuckle on the foot. That area is usually enlarged when you have a bunion. The degrees of bunion for a podiatrist or for a patient in terms of their pain has to do normally with the size of that growth or overgrowth of bone. Bunions can be very red in color, and that's usually associated with the friction of the individual who hasn't cut out their shoe. It could be associated with a bursal sac, which occurs between the skin and this enlarged bone. It's the body's way of trying to protect this enlarged bone. So anatomically speaking, it's normally on the side of the foot behind the big toe. The bunion, however, is, I guess, a deformity which you have to control. If Mr. Flash came into my office with a bunion and told me he doesn't like the way it looks, my antennas go up right away, because when someone doesn't like the way that it looks, doesn't necessarily mean it's something that has to be operated on or corrected. And when I see a case such as that, I'll simply say, well, if you don't like the way it looks, how about we stop it from getting worse? What can we do to help that? Usually bunions are caused by inheritance, which is a topic we've touched on a little bit before, and foot structure. The inheritance I cannot change, and thank God I can't change that. But what I can change is the way a foot functions, and that's where the mechanics come in. If you can take a foot and control the way it hits the ground by putting an orthotic in a shoe, or putting what used to be referred to as a cookie in the shoe, but in this case a sophisticated cookie made from an impression of the foot, like a dentist makes impressions of teeth. Send that impression to a laboratory and make something that will make that foot balance, and I guess that's a good layman's term, balance better in its gait and in its stride, will control that deformity from getting worse. That's usually the first line of defense before surgery is even contemplated. And if Mr. Flash came in and said, this is the worst and most terrible bunion in the world and it hurts, and doctor, I want it removed, then Dr. Rinaldi better think twice again before he considers removing it, because what Dr. Rinaldi and most podiatrists will do first is something conservative. That could be some form of an introduction of medicine. It could be a steroid. A steroid which works in that area, does not go through the body or the system. A podiatrist may render some form of physical therapy, whether it's an ultrasound treatment, whether it's an electrical stimulation treatment, whether it's a paraffin wax treatment. All of those conditions will reduce the inflammation of this terrible pain Mr. Flash came in with. Certainly today we have these lasers that do wonders for the inflammation. Lasers can be used to penetrate through the skin and reduce a lot of the inflammation around the bone. Once all that's accomplished and Mr. Flash is wonderful and he's wearing his orthotic, then everything should be all hunky-dory. In those cases, however, which we don't get the relief, we don't get the improvement, that's when we sit down, we go back into the consultation room, pull out Mr. Flash's x-rays and say, you know what, I think it's time we started to consider surgical intervention for this bunion and think about all the risks associated with it and go from there.
Tell us a little bit about, so basically when you tell surgical, you said it's a deformity of the bone, so you're obviously doing some cutting on the bone. You shave it down, I don't know what. But tell us just a little bit about what that really entails in very short layman's terms. And also, you said, all the risks associated. Give us a laundry list of of risks here.
Of course. The most simplistic bunion operation, and there are probably, I'd hate to even venture a guess, but let me do so. Probably about 30, 35 different types of bunion operations that can be performed depending upon the type of bunion we're dealing with. And rather than get very complex, the simplest thing is to remove the bump. You use the expression shaving the bone. Well, a surgical saw is used, the bone is removed, and we try to remove it consistent with what would be a straight bone. Most times, however, that is not enough to correct a bunion. Sometimes we have to move the bone. We may have to move the bone in, we may have to move the bone out, we may have to move the bone above the bunion to create an alignment that is satisfactory to prevent that bunion from recurring. Sometimes internal fixation, the introduction of a screw, a wire may be utilized to control the deformity during surgery, and sometimes that wire is removed, sometimes those screws are not. As far as complications, there you go. I started mentioning screws and wires, etc. Those are foreign bodies. When you have a foreign body in your body, there's a potential for a foreign body reaction. Any surgery, whether it's the foot, the hand, the back, is prone to infection. Anytime you cut through the skin, you're prone to some form of a paresthesia, a fancy name for a slightly anesthetic effect to the skin where you say to me, doctor, it doesn't feel the same. I can't feel that fine pin, that fine discrimination of sensation that I used to feel. There's also a chance of recurrence. My goodness, sometimes bunions do recur, especially those that aren't followed with some type of a mechanical control, such as an orthotic.
I see. Well, there's a lot to it looks like, and very obviously self-diagnosing would not be a good thing. So basically, always start off with almost like prevention and with not very aggressive ways, trying to make sure that the foot is balanced, try to fix it that way. If that doesn't work, which I'm sure you see relatively fast, let's go do this surgically if we have to. And I'm sure that whatever pain a person has with your laser ways and with your medicines, that can be handled relatively right away. Am I correct? Regardless of whether you then modestly try to adjust the structure of the foot, or whether you go in and put screws in it, the pain probably can be gone right away, correct? No?
Yes, I tend to shy away from words like right away.
Oh, okay.
I certainly do, because one of the hallmarks of being frank with a patient is to give them realistic expectations. Foot surgery is a difficult surgery in terms of the position the patient must go to following surgery, which is weight bearing. So we're compromised as opposed to doing hand surgery where you can splint it. That patient is up and going. So, but what I want to emphasize, as you already have, is the approach: prevention, conservative treatment, the mechanics of the foot, and then a surgery if that's the answer.
Good. But if not instantaneously, you can get rid of the suffering the patient has. Maybe not so fast of the look, because that may take a little longer, may take some surgery. But the pain, the discomfort, you can handle relatively soon. If that's a good word, right?
Yes, without question. Yes.
Good. Well, Dr. Rinaldi, again, very informative. I'm sure patients, especially with a bunion or knowing somebody with a bunion, will enjoy it and will now know much more what to do. Thank you very much.
It's a pleasure, as always. Thank you.